Today I'll be giving a talk on whether infection prevention and control within mental health settings should have a more public health focus. So as we transition away from the COVID-19 pandemic, we need to refocus on the longer term priorities to reduce avoidable ill health through some of the public health messaging and strategy that already exists and is in the pipelines. So we already know that infection prevention and control has complex challenges within mental health settings, and it's traditionally seen as an acute related service. As individual practitioners, however, and a collective workforce of specialists, we need to adapt infection prevention and control to be relatable in these settings and how it can also reflect the needs of the population. We have increasing health inequalities between our population of service users accessing mental health needs as well as the wider UK population. A lot of the key drivers related to health inequalities and reducing that gap are key drivers closely related to infection prevention and control remit. Those with serious mental illness are at greater risk of communicable disease, and we do need to have a greater understanding of epidemiology in the community and how that influences the prevalence in our services. We also need to strengthen our links between the local NHS trusts and the integrated care systems and the strategies for effective joint working. So a little bit more evidence around this is those with serious mental illness are at increased risk of poor physical health, and we know that that increases their susceptibility to infections, communicable disease, and increases their mortality and morbidity rates. Those with mental health illness are twice as likely to smoke. We know that increases their likelihood of COPD diagnosis, but that also directly impacts on the increased rates of acute respiratory illness and community-acquired pneumonia. Touched on it earlier, but we know that there are increasing health inequalities and there is less equitable access to healthcare in those deprived groups. And a lot of our service users do belong to those deprived and underserved groups. Prison services, is there something that we can learn from prison population health where we have similar risk factors that can be applied in our forensic services amongst the other types of settings and the ways in which our service users live and are housed? So some of the current initiatives that we need to refocus on is the NHS long-term plan. Chapter 1 provides us with the how, and Chapter 2 identified 5 key drivers for increasing demand on NHS services, some of which are avoidable. So every 24 hours, the NHS comes into contact with over 1 million people at moments in their lives, and the long-term plan sets out practical action to how we can utilise these contacts for positive opportunities to help people improve their health. One of the questions for me is, how can local infection prevention and control teams support the implementation of the long-term plan? And do we need to have further research on the links between serious mental illness and communicable disease? When we look at those 5 key drivers around Chapter 2, we know that there's an increase in demand for mental health services within the ageing population, and these are some of the most vulnerable cohorts physically who access our services and who we often implement the most stringent control measures to protect. Evidence shows us that the most deprived areas have the highest rates of unmet mental and physical health needs, and do we need to stop lineating those into separate categories? We already have a national focus on the shorter term challenges, such as accident and emergency waiting times and those who are trying to access mental health services in the first instance. But are we doing enough to progress on the longer term priorities that require extended research and funding without immediate measurable data in communities? Infection prevention and control specialists were becoming more involved than ever in the built environment, a legacy of COVID-19 pandemic. And do we need to ensure that all of the healthcare settings are fit for purpose, bringing those traditionally non-acute settings up to optimal standards particularly around ventilation, whilst working with our colleagues as part of the multidisciplinary team on making sure that those settings are trauma-informed. We can't continue to apply downstream prevention, so preventing complications of those with existing chronic diseases. Instead, we need to focus on preventing occurrence in the first place in our communities and how that influences the service users to directly access our care. So the NHS long-term plan informed the NHS prevention programme and in turn the National Healthcare Inequalities Improvement Programme. And the Global Burden of Disease study in 2019 identified 6 risk factors for early mortality and health inequalities. And I'm sure you'll agree that all of these risk factors directly impact on our groups of service users accessing community and mental health care. And that's smoking, poor diet, obesity, high blood pressure, and drug and alcohol misuse. So as I say, these are all significant for those service users accessing mental health services. And the Core 20+5 really helps inform the need for those physical annual health checks in the second key area of focus. But also you can see on the third key area of focus is chronic respiratory disease. And we've got within that the increasing uptake of vaccinations and immunisations. Ultimately, the aim of the Core 20+5 is to detect and treat diseases earlier through targeted screening of rare infectious diseases. And I think that there's an element that we've lost sight of that as we've come out of the COVID-19 pandemic. So coming down to a more local level, within North Central London Integrated Care System, so their formal introduction into legislation in 2022, so during a very difficult time for us in healthcare, the integrated care systems, such as NCL, strive to improve the population health by joining up of services across NHS providers, the voluntary and private sector, and local authorities. But I think, again, another question is, do we all know what our ICS strategies are and what their priorities are within our local areas? And more significantly, have these truly been embedded after the challenges of a global pandemic? So I'm now going to have a little look at 3 of the longer-term strategies related to public health and hopefully encourage us as IPC practitioners to evaluate where we're at individually and collectively in delivering against these outside of the acute setting. Mycobacterium tuberculosis, it is still a problem. The TB Action Plan for England has been overshadowed by the COVID-19 pandemic, and the 1.8% increase rate in notification in Table 1 is believed to be directly a consequence of the disruptions to TB diagnosis and treatment. If we can improve the detection, prevention and control of TB in England, this would support a year-on-year reduction in TB incidence and transmission rates and enabling our commitment to the World Health Organisation's targets by 2030. The TB Action Plan for England, you'll see, is nearing to a close in 2026. And again, this is just really for individual practitioners, but also as the workforce, to collectively evaluate whether or not we're on track to achieving those targets. What's really interesting here when looking further into tuberculosis notifications is that almost 17% of people diagnosed with TB in 2021 had a social risk factor, which you can see in Table 6. And I'm sure that you will all agree that these social risk factors directly correlate to the social risk factors of those with mental ill health and other communicable disease. Second is looking at antimicrobial resistance and evaluating where we're at. So prescribing of antibiotics in England increased in 2022 after years of decline, and all settings apart from dental saw more use, with total prescribing increasing by 8.4% in 2022 compared with 2021. So we already know that acute hospitals are treating increasing numbers of multi-drug resistant infections. However, antimicrobial prescribing outside of the acute hospital, but particularly within mental health settings, is at times suboptimal, and it's highlighting a continued need for education and engagement of all prescribers, administrators, and users of antibiotics within this speciality. So really we need to be looking at, are those prescribers, such as psychiatrists, up to date with the evidence base on what they need to do to contribute to AMR. So fantastic lessons have already been learned on the public health messaging through the COVID-19 pandemic. And with continued engagement of underserved and hard-to-reach groups, could these strategies be applied to increase uptake of immunisations and vaccinations, which we know is one of the most effective methods of prevention, particularly around tuberculosis? A good example of this is also within our child and adolescent mental health services, and utilising the notion of every contact counts to improve knowledge around childhood immunisations and the importance of these. We know that ethnicity and social deprivation correlate with higher rates of serious mental illness, as well as for resistant infections. Bloodborne viruses. So in relation to bloodborne viruses, we have the Towards Zero HIV Action Plan for England, and again, this is also drawing to a close in 2025. And there's still approximately 4,500 people in the UK with undiagnosed HIV, and the government's aimed to end all new HIV diagnosis by 2030. Again, evaluating, are we on track with these strategies and implementations? So great improvements have already been made on targeted screening for HIV, hepatitis B and C, and there was a funded pilot supported by the National AIDS Trust and Elton John AIDS Foundation. And this pilot was in areas of high HIV prevalence, and it initially was rolled out to 33 accident and emergency departments for opt-out BBV screening. And this was reviewed in 2023, and due to the successful rates of identifying those with HIV, hepatitis B and C, it's been further expanded to include 47 accident and emergencies of areas with high prevalence. So through this targeted screening, we can reduce transmission, reduce mortality, morbidity, and therefore the susceptibility to additional infections and communicable disease within this group. Additional ICS, local ICS initiatives include the development of the population health nurse role. So within North Central London, these professionals provide BBV screening to all service users accessing drug and alcohol misuse services. So with the pilot in accident and emergency and the rise in prevalence amongst our groups of service users, could we learn from this accident and emergency pilot and perhaps look at other ways that we can transition targeted screening directly within our services? This could pave the way for more targeted screening with similar risk factors. So again, coming back to the notion of prisons where there was an earlier pilot similar for opt-out BBV screening, and where we have areas such as our forensic services, medium and low secure, with similar risk factors, could we utilise these pilots to improve the health of those populations? So what's next? The King's Fund highlighted 3 areas that we need to tackle increasing health inequalities. Firstly, I think this starts with education, so education of the wider workforce. We already know that there's some fantastic tools out there, so the National Infection Control Manual, we've got the IPC education framework, and also the NHS Matron's Handbook with a heavy emphasis on our clinical leads playing a more significant part in ensuring IPC measures are implemented. I think we also need to review our higher education of our IPC specialists and perhaps move away from those modules that have an acute focus and make sure that they are relatable to the areas that we work. As multidisciplinary teams, so we continue to see the healthcare workforce increasingly become more specialised, And I think we really need to enable all of our healthcare professionals to feel confident in engaging and promoting holistic health opportunities to reduce the prevalence of infection. As individual practitioners, what can we take away from refocusing on these public health strategies? And perhaps have we lost sight of prevention is better than cure? So we already know that trying to implement infection prevention and control precautions such as isolation within our population is really, really challenging, and perhaps we need to think about outside the box and concentrate on that prevention rather than cure. Through national and local partnerships, we do really need to understand the wider local integrated care system initiatives to address these health inequalities and how they relate to any of the national or international targets, how we as these IPC teams within mental health settings can directly support and contribute towards these targets, working collectively as one health economy, reviewing what we have, what we need to do further, and what can be improved on already. An example of this could be arranging for mobile TB testing units through collaboration with our local TB services. And this could be something that contributes to that targeted screening of rare infectious diseases by providing much needed opportunity to access screening in our highest risk groups. Working closely with our colleagues in NHS England and also UKHSA, as well as our local health protection units, to try and bring all of these strategies together in a real workable form. Through effective local leadership, again at multiple levels, we can identify appropriate populations for some of these quality improvements or initiatives to take place within our inpatient and outpatient services. So this can strengthen the existing strategies, but also consider those new and innovative ways to engage those underserved and hard to reach people. We have a really strong emphasis at the moment within healthcare on continuous quality improvement. However, these are usually to inform or implement effective short-term interventions, and within mental health services, an obvious focus is around improving the mental health of our populations. But I think there really needs to be some wider quality improvement across the whole health economies to implement those improvements that may be slower in delivering the measurable outcomes at a holistic level. Additional funding is needed for research and development of the epidemiology of communicable diseases in our communities before they're reaching the acute hospitals, such as shifting surveillance away from mitigating healthcare-required infections and focusing on how we can improve disease detection, stratify those risk factors, and understand the variations in strains to combat that changing epidemiology. And I think a really good example of that is the rising rates of C. diff in our community. I'd like to thank you all for listening, and I really hope that this inspires you as individual practitioners and, again, the wider workforce to go away and reflect on the preventative strategies that are already in place, what more needs to be done, and how this developing and evolving speciality of infection prevention and control specialists can help improve our health of the population, reducing the occurrence of infections and communicable disease. So thank you.